So we've got about 16 slides, I think, that will go pretty quickly, but feel free to jump in at any point and take us off the slides. They're just prompts to give us some ideas of what you might be interested in. But if you're interested in other stuff, the purpose of these sessions is to talk about what you want to talk about, okay? So with that, I'll jump right in. First, just some acknowledgments. These things, I hope people appreciate that there's lots of recognition that happens here, and our work is getting recognized not only locally, regionally, but nationally as well. And so here's some examples of some. The D Magazine Excellence in Nursing Awards were announced. We had 45 nurses in that. I think that's a record, Donna. Is it? Oh, wait. 45 out of 98. So pretty much our nurses are dominating quality in this area, right? Don, is that how you said to say it? We also had 15 named in the Great 100. That's another sort of nursing recognition program. And they'll be honored on the 18th of April at a ceremony at the Meyerson Symphony Center. We received the THE, Texas Hospital Association Bill Aston Award, which is their top quality award. And that's for a project that Donna Prasad and her group did around HPV vaccinations in our clinic. So this is a multi-year project that showed significant increase in HPV vaccination rates, and a nod to the work that we do on population health. And our community health specialist, or community development specialist, won UNT's Health Science Center's first Unsung Heroes Award for their work in public health. And there's more. So HIMSS, which is the National Information Management Society, they have an award called Davies, which is their top national award. And they award it to a handful, 2, 3, 4, 5 maybe, centers across the country. And they came and did a site visit at Parkland. And before they left, they said, you guys are going to get one of these. And in fact, we did. And that was for the work around a few of our projects, one of which was our outpatient parenteral antibiotic therapy program, which is the home IV antibiotic program that Dr. Bhavan and her team have put together. We're also named Greenest Hospital by Becker's, and our procurement team was recognized by the Women's Business Counseling for having the highest % increase in the number of women business enterprises that we use. So we track, we do a lot of construction, we do a lot of purchasing, and we want our purchasing activity to reflect that we're part of the community. We want to use businesses in the community, and so we pay attention to minority-owned, women-owned businesses, and we try to include them when we can in our work, and we got some recognition for that. Anybody in behavioral health here? Behavioral health is like an ongoing challenge, not only for Parkland, but for all of Dallas and across the country. One of the things that we are participating in is a new program to try to take care of some of these crisis problems in the community before they end up at the emergency room or before they end up in jail. So you'll hear stories from time to time, the police were involved in a case, there's a shooting, and the person had mental illness. Well, the idea behind this program is to send out a mental health professional with paramedics, with police, to try to diffuse situations in the field with a mental health expert rather than having the police trying to figure it out. And so we are now participating in this program in Dallas, whereby we have a social worker at the control center. So they're taking the calls, filtering those calls, and when it's appropriate, this right care team will go out, and we're able to assist the police in diffusing situations rather than having those situations escalate in the field. And the early returns are we've been able to decrease those cases from having to go to jail, having to come to the ED, because we can connect them with community resources in real time. Also, to try to meet some of the demand in psych, we've asked for a waiver to double up some of our beds in the psychiatry area. So we've asked to double 8 rooms so we can go. We can increase some of our inpatient capacity, and ultimately we plan to build out. We have 6 shelved rooms on that ward, and we plan to build those out as double rooms. And so once all that is completed, we will have doubled our capacity from 14 to 28. But the first step is we're trying to get a waiver from the state so that on cue, look at Lisa Veddersen, state regulatory person in charge of that waiver. And that's going to happen next week, right, Lisa? That's what I keep asking, but she says it's a few months. So I'll take, it's a few months. Okay, our nurses are on a journey to the pathway to excellence. And basically this is a recognition program by the American Nurses Credentialing Center that is recognizing, that will recognize our nursing program for, I don't know, I guess it's engagement, quality, and so there are 6 standards that we've got to show proficiency in. Does anybody know, can anybody name any of the standards? Donna, did you see my email to Karen? I got 4 of them without even looking it up. Anybody, any nurses here? Because you're going to be tested on this. So ANC is going to come and they're going to do a survey on site. We submitted the application. It was 800 pages. Seriously, it was a big application. That's been submitted, and then they'll be on site to survey. So anybody know any of the standards? Somebody's saying some. Leadership, quality, safety, well-being, professional development, and I'm missing one. Shared leadership. And so I think there's a lot of momentum in nursing now around things like shared leadership and participation in decisions that get made in your area. And this is, the point of this is to put some structure around that and engage all of our nurses. You know, it's such a big part of the work that we do here, and we want and we want to have people feel to feel good about the work, feel that everybody's contributing and have a voice in the work, and so and also provide opportunities to develop their careers. And so that's what the Pathway to Excellence is about. And you can learn more on the internet, on the intranet at that site. Patient Safety Awareness Week is coming up. There'll be a lot of activity going on around that. You can check the intranet for specifics if you want to nominate a patient safety champion. I think it was in Parkland now today. You can look up at how to do that. And basically this is, again, just sort of it's a week for us to stress the work that we do all the time, but it's to put some extra focus on our efforts around patient safety. I'll tell you this, I was looking at our Medicare performance just this morning on how we are doing, and it's been frustrating in the past years because those Medicare metrics lag. There's like a 2 to 3 year average that they run, but you're starting to see in our numbers now the work that was the results of work that's been done over the past several years, like reduction in the hospital-acquired infections, particularly, are starting to show up there. And so this is a week to put some emphasis on that work that we do all the time around safety. We've had a number of surveys over the past few weeks. The NICU was recently surveyed, had a great survey. One of the surveyors said it was the best level 3 NICU they've seen in the state. And so an example of excellence there. One that's not on this board is the ADA survey. American Diabetes Association did a survey of our global diabetes program. And one of the comments that the surveyor said from that survey is, this is the biggest program they've ever seen. And so 2 surveys, one saying it's the biggest, one saying it's the best, and that's what we want to be, right? And that's important because we want our patients to have confidence that we're very good at what we do. And so these surveys help us to be able to demonstrate that and keep us, focused on the work. The trauma program was surveyed. We had a very successful survey of our trauma program, and we're in the window for Joint Commission, which means please pay attention and be ready. The Corporate Integrity Agreement. Does anybody know when the end date on the CIA is, 5-year Corporate Integrity Agreement? May 31st. So at May 31st will be the 5-year, I don't know, anniversaries. All right, that's the right reaction. And we expect to graduate from that agreement. Now we have to be released by the OIG. We're doing everything we need to do to graduate from that agreement. When that happens, the work that we've done to get to that graduation doesn't end. And that's the point of this reminder here is, there's so much work being done in our infrastructure for things like quality, for compliance, on the compliance side, to check ourselves to make sure our billings are being done correctly. We do a lot of internal audits. We check ourselves. We provide hotlines so people can call in, compliance ways people can call in by name, anonymously, if you've got things that you don't think are right that are happening here. And so we want to keep up all that activity around compliance, and we certainly want to keep up all the activity and build on what we've done in the quality sphere. There are two kind of arms to that CIA, compliance and quality. And so all of that activity, it may look a little different in the future. We won't have to do all the same reporting that we've done in the past, but the activity is going to stay the same because we don't want to lose the momentum that we've created. I can tell you, I've seen a lot of hospitals. I don't know if there's one that pays more attention to quality, trying to identify places where you're at risk, identifying near misses, and putting systems in place to correct it. I'm not sure if anybody does it to the degree we do, and we want to be able to continue all of that. So along those lines, so in February, you're going to be assigned training. You should be used to this. It comes every year, and that's our CIA training. Some form of that will happen in the future. Like I said, it may be crafted a little bit differently, but we want to be able to continue to do the work so we don't lose the momentum that we've created under the CIA. Facilities update. We expect to sell the old hospital site at the beginning of April. We're under contract now. We've been under contract for some time. We're in an inspection period right now, but the buyer has $3 million of non-refundable money in the deal now. And so if the deal goes away, meaning there's quite a commitment from the buyer. We think it will happen. But we won't know until we close, and that'll be the beginning of April. When that happens, everybody that was working on the other side of the street before the beginning of April will continue to work on the other side of the street after the beginning of April, because we'll lease back the space from the new owner until we have an opportunity to provide a permanent home for everybody that's on the other side of Harry Hines. And so that process will take up to 3 years, and will include us building some space. So we'll need to build a clinic over here. We're going to need to build a parking garage over on this side of the street. So some of that will be construction. Some of it will be leased space, likely for some of our administrative functions. But so that's going to happen, we think, at the beginning of April. We'll lease back so people don't have to worry about getting evicted. You'll stay there, and we'll have an orderly transition. And I know Building B wants to be evicted, but it'll be an orderly transition. And let's see. You'll see some activity around a new parking lot behind the logistics building. That'll be a surface lot. You've probably heard that we bought the church property. You know that property on Medical District? That's kind of the indentation in the parking lot. We now own that, and that will be, at least for the immediate term, we'll turn that into probably some admin support space for stuff that has to move from the other side of the street. Okay, our strategic plan update. Remember, we have, the strategic plan. It's a big plan. There's a lot of goals and tactics in that strategic plan. We have identified 3 that we've created as system-wide goals for the organization for the year, very similar to what we had for 17. We're doing the same thing for 18. So the 3 system-wide goals that everybody will get scored on are one's around patient experience, and that is on the patient experience survey. There's a question about likelihood to recommend the hospital. So there's a summary score for that we, a target score that we will need to hit. There's a goal around quality and safety, and it has to do with 2 patient identifiers. And so the goal is that we will have 2 patient safety identifier with a harm score of 3 or higher. That is 3.1% or less of all safety posts. Basically, have a low percentage of our safety posts be related to 2 patient identifiers. So do your 2 patient identifiers every time. And then one is around cost of care, and basically saying that we'll finish favorable to budget for the year. So those are 3 goals that we try to look for things that everybody in the organization could have a part of, which is very difficult to do. but these are 3 summary goals that we all will be scored on similarly. And I'm going to come back to that in just a couple of minutes. The merit, I don't know if any of you in this room sort of were concerned when the merit matrix came out for 17, but there were some concerns the way that was rolled out. We had some mistakes on our end on how it was rolled out. But just to let you know, we ended up using the same merit matrix for this year, for 17 than we've used in prior years. So we budgeted 2%. For the past several years, we budgeted a 2% raise, and then it gets distributed according to a matrix that, and basically the factors of it are where you sit currently within your pay scale and what your performance was. And so there's a matrix, and depending on that, you end up with a raise anywhere between 0 and probably 3%, or maybe it goes up to 3.5%, I don't know, but something like that. But on average, we budget a 2% raise. We've done that for the past several years. We did it again for 17. I can't for 18. For the current year budget. And so but I tell you, when we looked at the matrix, because the matrix was originally changed a little bit this past year, and to fit the 2% raise. And when we looked at it, we realized the matrix we've been using, it's awarding more than a 2% across the board. It's probably awarding closer to 3%. So that'll be something that we'll take into consideration when we craft the budget for 19. But just to be clear, what was distributed this prior year was consistent with the prior matrices, and you've experienced probably somewhere up to a 3 or 3% plus in raise on that matrix. Y'all stop me if I'm being confusing here. Something new that we are doing, let's see. Oh, before I get to the incentive, this is about your goals for 18. So everyone should have your goals for 18 in Pathways. If you don't, please talk to your leader about that. This is something I actually personally find it useful. I do the same thing that you guys do. Every year I sit down with the people that report to me. We go over their goals, how they did, and then we talk about what those goals for the next year will be. We've tried to give some guidance and craft them in accordance with our strategic plan. I will get kind of specific on some of them. If there's some project that I want to make sure we get done this year, I'll assign that as a goal. And when it's on paper as a goal, people tend to pay a little bit more attention to it, and it tends to happen. And so if you don't have your goals in the system now, you should. And so talk to your leaders about that. And if you do have them in the system, then pay attention to them and make sure you get all your goal met by the end of the year. So this is just a prompt to say, get them in, and if they're not in, talk to your leader. On the engagement front, you should all be aware of the action planning around employee engagement. This is something that I've started to watch a little bit more, just because it's a measure of how we're doing as an organization, not necessarily because I want to chase a number. But the work at this place is it's meaningful work, right? I mean, you're making an impact on people's lives, and so if people are coming to work and they're not feeling engaged, if they're not feeling good about the work that we're doing, then as leaders, I don't think we're just not creating the right environment. We're doing something wrong, because the work has intrinsic value, and so. We will pay attention to this, because if there are areas where engagement is low, if people are sour about their work experience here, then we've got work to do as leaders to identify why that is and to address that. And so it's something that we're focused on. When you and so every area, based on last year's engagement survey, we identified issues to focus on that people would have some control over. So we didn't want to have, let's say, frontline worker having a goal around meeting budget for that area or an engagement, or or something they had no control over. And so So Vishal's team looked at what are those areas of the organization that you could identify goals based on opportunities of influence. And so at the employee frontline level, the goal is my team works well together. So we have good teamwork in our group. And teams were asked, or units were asked to develop strategies around how you can address that goal. At the management level, the goal is, or the objective is, I'm involved in decisions that affect my work. And so we talked a little bit about shared decision making. How can you include people in decisions that impact their work? And then at the senior management level, we have a objective too, and it has to do with confidence in senior management's leadership and what we can do to work on that. So all levels have their objectives and should have action plans. You should be aware of those things in your area. And again, it's kind of hard to it's hard to be too prescriptive about engagement and what the kind of mood, culture, feel in your unit is like. On the other hand, there are some things you can do if you pay attention to it. And if you look at the data that the survey respondents are giving us, and you say, you know what, people don't feel like they're involved in their decision making, because that's one of the questions. How can I look at, when we're about to implement something new, how can I get collective input before we do that so people feel like they have better input? And it's that kind of thing. So the point of this is try to put some structure around it. So that's our engagement. And let's see, the incentive plan. And so for this year, we will have in addition to the merit, which is a totally separate type of calculation, we have instituted an employee incentive plan. And this has to do with, the origin of this grew out of the fact that in years past, there used to be an executive incentive plan that the board put in place for VPs and up, and you could earn extra percentages of your pay if you hit certain performance measures. Well, I'm not a big fan of that, and in discussions with the board, we got rid of that program. But they wanted to have some, or there was some discussion about, it's good to have some incentive-based program as an organization. So what we proposed was a broad base across the entire organization. So rather than VPs being able to earn 15, 20, 25% incentives, we couldn't do that same level for the whole organization. But instead of doing that, we agreed we could budget for a 2% incentive across the whole organization. So on those three goals I showed you, one around budget, one around two patient identifiers, and one around patient experience, depending on how well we do on those three, as an organization, we will earn up to 2% of an incentive, and that will get paid out at the end of the fiscal year. So maybe we're looking at January of 19. If we can push it up and get it done, we can get it all scored and get it done before then, we will. But an opportunity, separate from the merit, to earn an incentive. I'll be curious to see if that's something that people find useful, not useful, a distraction, or something that is useful. If we were focusing on it, everybody would know those three system-wide goals, right? Because the whole idea is, if you know those goals, and it could be a 2% incentive for you at the end of the year, everybody would be focused on and working on it. I don't want to put anybody on the spot, but just think about it in your head. If you know those, if you knew those three things before I said them, and if not, you should be spreading them around to people, because that's going to have an impact on a little bit of an incentive at the end of the year. Let's see. And then finally, I'll end with just a couple of these slides on our new employee assistance program. We have a new program. You can go to the intranet and identify the program, ComPsych, and it offers counseling, legal, financial consultation, crisis intervention, work-life assistance. So it's a support function for employees, and you can get to that through our intranet. And if you need help, you can go to OTM's website, and it will walk you through how to get to ComPsych. Along those lines, there's also a new program that will offer savings and discounts. That's called Beneplace, and you can find that at the same place. You can go through OTM and find that as well. And then a new health and wellness benefit that's available for people, and it works through our employee health plan, and it's a weight loss program. And again, you can find that through OTM as well. I just go to OTM's portal. Have people used that portal? They tell me in OTM, it's like, it's magic. That's what Misty's group has said. But no, that group, they just presented at the board the other day, and I think there's a 70% first call resolution. Like if you call that portal, either the phone or the online, you should be able to get your questions answered pretty readily. And if not, there's a way they'll direct you to people that can get you into get more detailed if you need further assistance. So those are a couple of new benefits that OTM has identified and will be providing this year. So that's a few of the things that are going on, and certainly not everything going on around the place. So why don't I stop? Let me see how I'm doing on time. So we have plenty of time for questions if you guys want to talk about something else. Anybody? Lauren? This morning, what was the other group that have?
Do you want to talk about a broader facilities update, anything coming on the market, anything we're purchasing, anything we're looking towards?
We are looking. Let's see, a couple of things. You should start to see activity sometime soon on top of the ambulatory surgery center. We're going to move the breast center from its current location, and we're going to build 2 floors on top of the ambulatory surgery center and do that. That is a project that is actually brought to us by our foundation. The foundation is going to fund that project. There's some people in the community that are supportive of that issue and really recognize that the space that we're in right now is really not adequate. And so they've been able to generate, it's about a $40 million project. They've already raised $28 million. And so the work is being started on it. The planning is in progress now, and so that'll be happening. We'll have some added space there, and we haven't decided what other clinical activity will go there, but it'll be primarily the breast center that will go into those top 2 floors. We will be looking at, in the short term, identifying some leased space to move close by, to move some of our administrative functions that are over on the other side of the street. The person who, and then like I said, we have to build a clinic over here because we still have a lot of clinical activity in Old Parkland. And so we're gonna have to build a clinic, and that planning is being done now. We're sort of, trying to sequence it. We don't want to get ahead of ourselves because we want to make sure we have a sale. Because basically the way the math will work is we'll sell that building for about $80 million, and then we'll build additional space over here, which will be a little bit more than $80 million. But we'll have a new clinic and parking that will go along with that. So we need to make sure we got the sale done. But we're doing that planning, and things will start to pick up quickly after April. Let's see. What else on the?
How would you be putting that building, the clinic and the parking garage?
Let's see. So the parking deck, I think, is going to be just on the back side of logistics. So over here, and the clinic, I think, is going to be just on the other side of the Dart line. So all on this, it was kind of just using this campus, taking some of our parking and converting it to structured parking, to be able to accommodate the clinic growth. Let's see. When we move out, the new owner plans to do some very nice things to the old building. So he plans to invest like $250, $300 million in that property, and plans to use the put some parking beneath the old hospital and turn it into mixed use, some residential, some retail space. And so it'll be micro units, so apartments, small apartments, and some condo, hotel, and then some shopping, things like, he said he wants to get a Trader Joe's. I don't know if that'll happen, but that kind of stuff, some food and shopping in that area. So it should be very nice across the street once he's done with it. So let's see, so that's facilities. Anything? Yep.
We have one thing to say. I moved to Parkland 3 years ago, and I remember when I walked into the place where I was supposed to work here, I asked myself, what did I do? And in 3 years, you have changed this place. And not only you and your team. So we normally come here, we ask questions, are we doing this, are we doing that? But I don't know if we take the time to recognize what a big change and the great working conditions that we have right now. And I really want to say thank you for that, because I'm proud to say that I work for Parkland.
Well, thank you for saying, listen, it's a huge team effort, right? But the most important thing I heard was that you're proud to say you work for Parkland. I think the work here is good work, and oftentimes the public hospital gets saddled with a reputation. This place surely went through it. People that have been here for a long time know that, and you felt it more than I did. But this place does great work, and it's good now that you start seeing the community appreciate that more. There's a lot of listen. I just got asked by a group to go be on a New England Journal of Medicine Catalyst panel to talk about high-performing safety net systems. Now, that's so that's great for Parkland, because it just sort of lets the rest of the world know the good stuff that's happening here. But also, why is that important? We want our patients to feel that they're at a place that they're getting good care, and we want our employees to recognize and appreciate that they're at a strong place, right? And then that lets us build on those strengths. It lets us recruit strong people, lets us retain people. When people feel good about the place that you go to work, if you're going to work at a place you're not proud of, you're not going to stay. And so I appreciate that comment. I sure hope that people feel that, because we get good outcomes here, and I think it's a mission-driven place, and people give great attention to the patients and their families here. And so I hope people feel proud to work here. I know I do. So thank you. There was a question in the back?
Any additional longer-term projects as far as with parking structures being built and other advancements?
Yeah, there's a lot we're juggling right now between the sale and some of the new construction. But the two things we feel pretty confident that we need to do is the new clinic and the new parking deck. And like I said, the short-term, more immediate thing is the surface lot that you're going to see activity on probably starting next month over there on the backside of logistics. Longer term, we'll probably end up leasing some administrative space to relocate and hopefully close by from the old side of Harry Hines. And then long term, we would like to be able to accommodate much more of our administrative space on campus here. And that means, building something here and consolidating some of the off-campus stuff. But that's probably, that's a 5-10 year down the road issue. The other thing that I've asked our team to put some plans together for is how we would expand our outpatient footprint. The pressures that we feel on campus, the emergency department, the inpatient, are strong, and if we could do more on the outpatient side to try to deflect some of that, I think we'd take some of the pressure off of this site. And so I've asked our team to put together some planning around, what would be we know we got work to do at Vickery because it's a bad facility, and so what can we do to fix that, replace that facility, fix that situation, and then add the next COPC on the outpatient footprint.
that makes a big difference versus only being 6 days a week versus 7 days a week.
Yeah, no, I can tell you, we don't have an immediate plan because it's just not something that we had in the works. But you know, if that's something as Dawn looks at the activity in the ED, and I can tell you right now, if the way we sort of have looked at the world, if we can accommodate, you know, people are going to go to the ED, if we can accommodate that volume in the ED, then we won't open the pop-off, which is the urgent care center. And but if it's such that we have trouble accommodating that volume, that's when we've extended hours in the urgent care center. But I don't think we have an active work around that. Donna, you tell me. You're closer to it than I am. Doesn't mean we never would look at it. In fact, one of the things we're looking at in the clinics, as we take a closer look at our wait times in some of those clinics, one of the things that we know we have to do is increase some access. And we have a couple of options for weekend hours at some of our community clinics. What they tell me, and I haven't looked at these numbers closely, is that patients tend not to want to schedule on those, you know, evening or weekend hours. But I'm not sure how much we push that. But that'll be something else we look at too, because if we've got capacity and it's there for, you know, 2 out of 7 days and we're not touching it, then before we build the next one, maybe we should look at using the capacity we have and extend it to weekends. So that is something that we're more active on the COPC side in terms of our analysis right now. I'll tell you the other thing that's kind of cool that is happening on the clinic side is we know we can't. It's going to be very difficult to keep up with the demand. There's just a lot of demand at this place. So we're over 1.1 million outpatient visits a year. That's clinic visits. And so we've started some things to try to provide alternatives to the actual physical face-to-face visit. We've got a couple of years experience now in dermatology where we're doing telederm. The primary care provider takes a picture of the lesion, sends that through Epic to the specialists on campus here, and they're able to answer that consult without the patient having to make an appointment. You know, when that happens, the patient doesn't have to take off another day of work, drive down here, park, go to clinic. Our clinics don't have to do all that's, do the intake, the financial screening, the nurse intake, all of that. If that encounter can happen through a picture that gets sent across the medical record, then it's much more convenient for the patient, convenient for the providers, cheaper for the system. So we've got a couple of years of experience in dermatology where it's really reduced our wait time in derm clinic, and the patients like it as well, and specialists in high percentage of cases can read the image, can prescribe electronically, and so we can take care of the encounter like that. We've extended that to some of our specialty clinics. Our hepatitis clinic now is seeing a significant percentage of their consults through e-consults, email. So the primary care provider will email the specialist. Oftentimes it's a matter of looking at the electronic record, looking at the liver functions, and giving advice to the primary care provider. And again, we think that the people that are looking at doing this work with us now think that in a number of specialties, between 50 and 75% of those referrals can be handled electronically. That's the kind of stuff we're going to have to do more of to be able to accommodate the volume and demand that we have. And it's much more convenient for the patients if we can do some of that work. And in the process, at any point, if it turns out the specialist feels like I need to see this person, then it can always generate a face-to-face visit. But for those things of let me look at the liver function test, get these studies, and then they check this studies, and then they can make some prescribing decisions based on that. Oftentimes, you don't need to touch the patient to do that, and that's what our GI guys have shown us. So we'll be looking, a lot of work going on around how we can look at the way we deliver care so that we can meet the demand, because we know we won't be able to keep up if everything is the traditional one-on-one visit for every problem. Yes?
We seem to be having, in the past year, a lot more unfunded patients. We see a lot more patients with insurance, but then a lot more patients that don't have any kind of funding, and they're being, they don't qualify for
Uh-huh.
Used to be, you know, people would take care of them anyway. And now it seems like more and more services aren't willing to take care of them or see them at all. Our service is still trying to see them. But
Which service is that?
you're a gynecologist.
Here we go. Yeah. Yeah, it's a couple of things going on there. One, if you just look at the overall payer mix, it really hasn't shifted much. Our uninsured used to be closer to 50%, 47, 48%. It's around 45, 46% now. So uninsured has actually gone down a little bit. And that may be a factor of us being more aggressive about trying to identify options for coverage, you know, and do people qualify for Medicaid, do they have insurance? So that's one thing. So the overall mix hasn't shifted a lot, but I recognize that it feels like it has because we've gotten, we're paying more attention to it on the front end. We've had this is a tough discussion that we've had, and I think we're landing in a better place with this. And the discussion has been around how do we balance as the public hospital, the county hospital that gets county funding to take care of eligible uninsured people, and in our, you know, we set that at as 200% of the federal poverty level. If you're under 200% of the federal poverty level and you live in Dallas County, we will make sure you can get care here. What's happened is, and at the same time, there's federal legislation that was passed in the past few years that said if you make more than 100% of federal poverty, you're required to purchase insurance. That's the law. And you can get a subsidy to purchase insurance, but the law is you're required. Some recent changes to that, but for the past 5 years, that's been the case. And so our PFS people have been trying to line up our activities with the expectations of the federal law to say, okay, if you're in that 150% of poverty range and you're uninsured, you should have insurance now because you can get a good subsidy from the federal government to buy insurance, and that's the expectation. So they've been trying to push people onto that because then you don't spend county funds, you spend federal and private insured funds. So all the way trying to stretch the dollar. What's happened, though, is you have open enrollment from November to January. If you didn't enroll during that period, I'm uninsured. Yeah, I should have got insurance, but I didn't. But I still need care, right? And that's what that's probably the group that you're feeling. So we've spent a lot of time looking at our financial assistance policies, and I think we're about to land in a much better place now. We've done a significant amount of work around eligibility. You know, the line that used to be in old Parkland, that which people come at 3, 4 in the morning to line up, that doesn't happen anymore because of our eligibility process. We brought in somebody who has helped us work through that problem. So people can do more on email, we can do electronic verification of things. So first step was to make that eligibility process easier. Now we're trying to align our payment policies to be more reflective of policies that will allow that uninsured person to get care, but also not just don't check, because again, we do have some responsibility to the county to be prudent, and if we never check, then we'll spend all of our county money and we'll be going back for more money, paying for care for people that could have participated in their care. So we're trying to strike the right balance, and I think what's about to come out in the next few weeks, I hope, is going to be a policy that doesn't totally exclude somebody's responsibility. So somebody that makes 300% of federal poverty, they may have to pay 10% or some amount that's reachable, but still have some expectation, and those who are under 200% would still have a very kind of an easy way to get their care done. So it's not been a great process, and I own some of that responsibility because our own financial shop sort of independently did some work there that wasn't the right way to do it, and so we've had to take some steps back to try to get it right, and we're very close to putting out some new financial policies around that. Some people are still going to be frustrated because you're going to have that person that needs an elective knee surgery they're uninsured, they make 300% of poverty, and you're going to say, you know, we need some money up front. It's not going to be unaffordable, but it's going to be, but there's a mindset that I never should put anything up front, right? And so we're going to have to still deal with some of that, but I think we'll be in a much a more fair place than we've been in the recent past. Mm-hmm. Yeah. That was one when we put our strategic plan together, and we looked at, you know, making the experience better for the patients. You know, again, I'm ashamed that it's taken us this long to do it, but one of the examples was that line. You know, we did a really bad job with eligibility, but you should all notice. Hopefully, you notice. If not, tell me. But that eligibility process, we've greatly streamlined, made it easier for patients to get their financial eligibility done.
I've had patients comment on it.
Like I said, I'd like to say, yo, it's great. It is great, but I'm hesitant to gloat on that one because it took us too long to do that. It just, you know, that we ignored that line for too long, but now it's better. So I'm glad it's better now.
So regarding the whole financial thing, I schedule people in the GI, and some of them, all the procedures are elective, some of them have insurance. What is the number that you can give them in front of them to start that process to get financial aid? Is it the business main number office across the street?
Sure, yes, I mean,
Or
it's,
is there another line I can give them? Because I know part of the frustration on their end, when I speak to them on the phone, is trying to talk to somebody, so they can, you know, come in and start the
Right.
process.
so PFS should be able to help, and they have a way of escalating that, you know. So if it needs to get escalated so that somebody can make a decision, if it's, you know, if they can't manage within the, you know, the guidelines that we have, we always have the option for that. So, you know, whoever your PFS person is in that area should be able to get that done.
Okay, good. Thank you.
Mm-hmm. Yep.
Can we get an update on the hospital budget?
Yeah, so it's a tight year for us. This was a tough year to budget because of a few things. A short answer is I think we'll be okay. But it's you know, but it's a tight year, and the reason for that is, first off, on the front end, there are a number of things. We rely heavily on Medicaid with this program called disproportionate share, which is a Medicaid program. A lot of federal decisions were happening at the time we put budgeting together. State decisions, you know, the Medicaid waiver is a big part of our reimbursement. That was not approved when we were putting our budgeting together. And so a lot of variables that were unknown. We made some conservative estimates around most of them. We missed on at least one. We won on a couple more. And so this past week, when the federal government passed their budget and they delayed these DSH cuts, which is the payments for hospitals that do a disproportionate share of uninsured business, that was a big pickup for us. We got $13 million out of that delay at the federal level. And so there's a couple of pickups like that we're finding out about as the year evolves. And so we are running right. We're favorable to budget right now by a little bit, and I expect that we will. When I say a little bit, probably within a percentage point. You know, one of the other things that we did in our budgeting, and so we're missing the mark on our volumes. It was trended, and as we looked at the trends, we just played those trends out to the next year. But in reality, what we're seeing here now is we've sort of accommodated all of the capacity of this place, the hospital. And so, you know, as the volumes went up, process improvement things, we were able to run more people through. You know, we got into the new space, we grew into the new space. Then we did process improvement to try to get more people through the new space. And we're probably close, I think, to where we're going to be on that number. And so we projected a slope that we carried it out to the next fiscal year, to this year. And so our volumes, we're hitting last year's numbers, but we're not hitting our projected budget numbers because of that. And I think that's a sort of a lesson learned. You know, we're probably maxed out of where we're going to be. But the short answer is on budget. I think we'll, with good management, we're staying vigilant, we're watching positions, we'll have some work done around that. Vizient, who's our GPO, is going to be working with us, looking by department on how we're performing, how we're staffed according to benchmarks. This is not an exercise, it's not a slash and burn exercise, but it is, where are we on all of our, on a detailed level, how does the work units line up to our staffing patterns? And so as we look to continue to be more efficient, we'll be doing some detailed work on that around this year. But we don't have, I'm not fearful at this point that we're going to have to do anything drastic. We're not looking at layoffs or anything like that to be able to hit budget. I think we're tracking along where we need to be. Mm-hmm. All right. Anything else? Okay. Well, thank you guys.
Thank you.